which may be treated differently in different hospitals. Sometimes the anatomy gives us options to do resections. For example, in this pancreatic cancer, this has a 360-degree encasement of the common hepatic artery. You can also see it here. If you ask yourself, what is this? This were hemangioma. So this would be considered unresectable, but actually the patient had this anatomical variation of the liver artery with a replaced right and left. And this is the resection. Here is the stump of the hepatic artery, and you can see here the right replaced, and here the left gastric from which the left replaced comes off. So we have options sometimes offered by anatomy. Please keep this in mind. And then I want to say that after neoadjuvant therapy, resectability assessment is even more difficult. The common anatomical and radiological resectability criteria are not longer applicable. Why? Because pancreatic cancer has such a dense stroma. The cancer cells go probably away, but the stroma stays behind and is still seen as a mass around the vessels, and still formally, if you use the criteria, would be unresectable. We think that all patients who have no progression should undergo surgical exploration. And after the adjuvant therapy, the resection margin still counts with the 1 millimeter rule, as we recently published in the National Journal of Surgery. So how can we technically do this? I think we should use artery-first approaches, especially in locally advanced pancreatic cancer, but also in borderline and resectable, because this increases the likelihood of R0 resections and makes especially these complex resections safer. Then we should, at the arteries, go directly to the vascular wall, according to Inoue, a level 3 dissection, and this removes the nerve plexus with potential peroneural infiltrative cells. Of course, almost all patients with locally advanced disease do not only have an arterial involvement, but also venous involvement. And I think venous resections with different types of reconstructions, as here suggested by the ISGPS, should be standard. This is, for example, so-called type 3 resection, so a segmental resection with end-to-end anastomosis. The tumor is mobilized, the vessels are controlled, clamped, the resection is done, and an immediate end-to-end anastomosis. And if you do not have if you only have a venous infiltration but no venous obstruction, this can be done very safely and without increased blood loss. Another good option that we have, technical option, is wedge resection. And here, the peritoneal patch, this was developed by and described by DocMac from France, with a very good patency rate. And we make heavy use of this technique for infiltrations at the confluence, because you can then maintain all the vessels, and for left resections where the vein is infiltrated, because here you can not do a tension-free anastomosis in a segmental resection. If the tumors are even bigger, like this locally advanced pancreatic cancer with cavernous transformation of the portal vein and left-sided portal hypertension, we have described in the Heidelberg group 2 techniques: the cavernous, the venous bypass graft first technique, and the splenorenal shunt. And this tumor that you just saw is here resected. This was the shunt, shortened back later because this would be prone to thrombosis. And here a splenorenal shunt. And this can be done safely. You see that the small bowel is here not congested and absolutely looks good after this resection. If the arteries are involved, it's even more complicated. As I pointed out, the vein is also almost always also involved. And I will talk about divestment, which was possible here, and arterial resection, which was done here. For arterial resections, I think it's very important for divestment and resection. You have to be prepared for the resection, and you always have to have your strategy of a quick reconstruction ready, because you want to have short ischemia times of the liver and especially also of the small bowel. And there is different options. I do not have the time to go into this in detail. But here, for example, this was a case of a common and proper hepatic artery involvement, end of the bifurcation. And here we used an interposition graft of the autologous splenic artery between common hepatic artery and the right and left hepatic arteries. Until recently, these were the three largest series of arterial resections in pancreatic cancer collected over more than 30 years, with between 1 and 4 resections per year. Oncological outcome poor, but this was in the era, not in our era of neoadjuvant therapy, and not in the era of multi-agent systemic therapies. What we have to be aware of in these cases is that with technical complexity of an operation, also the risk of morbidity, but also mortality increases. This was a paper from Heidelberg. We classified standard pancreaticoduodenectomy, PD with portal vein, with additional organ, and with arterial resections, and you can see the statistically significantly increasing mortality. With this in mind, it is interesting that in specimen of arterial resections in pancreatic cancer, in this meta-analysis, less than half of the arteries were really infiltrated. So this offers probably the possibility to do, or gave also the rationale to develop the technique of arterial divestment, where you peel off the tumor, or after neoadjuvant therapy, probably the scar from the vessel, as you can see here. But clearly, if the artery is 360 degrees involved and you don't know if there is active tumor, you may cut through the tumor. And with this technique, we leave the oncological principle of en bloc resection. This is the largest series from our Heidelberg group, when I was also still in Heidelberg, of arterial surgery in pancreatic cancer, 385 locally advanced pancreatic cancers. Divestment was done after neoadjuvant therapy in 190, and resections in 195, but only half of them received neoadjuvant therapy because it was another era, starting 2003. And you see that caseload for both procedures was increasing, and in black you see the mortality always higher in the arterial resections than in the divestment. Both decreased over time, and here the oncological outcome, of course, there is a bias, also because of the use of neoadjuvant therapy, but approximately the same. And so this could be an option. This was a case that I did in Vienna, a young guy with locally advanced pancreatic cancer, infiltration of or encasement of the SMA and SMV. And I tried a divestment, it began to bleed, and then I switched to SMA resection and SMV resection. And the problem was that this guy was discharged without morbidity, but developed early peritoneal recurrence. And I had another such case. And there is a paper from Hopkins where they describe how you can estimate before the operation if there is the possibility of divestment, if you have a regular lumen of the artery in the angiogram, and if you have an irregular lumen, it's not possible. But I, because of this experience, changed my strategy in 360-degree SMA involvement to en bloc SMA and SMV resection, which is also called in situ small bowel autotransplantation. And I was asked to also present these data. So this is one case. You can see here the artery, here the vein anastomosis. And we always, if possible, for oncological reasons, leave the pancreas in. Some centers do total pancreatectomy. I don't think that this is good. Here is another case. Here the SMA anastomosis. Here an SMV reconstruction with this was a bypass first procedure with a shortened prosthesis. Another case. Here the SMA anastomosis. Here the SMV anastomosis. Here the pancreas. You can see the small bowel completely relaxed. You can do this very safely in a standardized fashion. This is an even more complex case. 4 SMA branches involved. We removed those 2. We reconstructed these 2. And you can see here also how the bowel looks nicely in this right lower corner. So it's I came from Heidelberg and had the experience, but it's difficult to build a program safely somewhere else, but we achieved it at the Medical University of Vienna. We do approximately 120 resections per year, and I started after 2 years with arterial resections, and we do approximately, so since 3 years, we did 27, so at the moment 10 per year, increasing, and 9 in situ small bowel autotransplantations, still small numbers. But in this, I did 2 conversions from divestment. Now I skip divestment and do primary en bloc resections. We have no mortality, no pancreatic fistula in 8 pancreatic duodenectomies. This is mostly hard pancreas, and we just published a standardized approach to it. And this will come with a movie if you want to look at it, but it's not yet cut, the movie. What is the disadvantage? But by the way, the disadvantage of both divestment and resection, patient, you make a denervation of the small bowel and you have neurogenic diarrhea. We are currently in the ISGPS developing a definition and treatment recommendation for this. The largest experience I should note is by Ugo Bocci from Pisa, and he also characterized the diarrhea and showed that after 6 months the diarrhea goes away, but until 6 months this can be quite bothersome for the patient. Talking about outcomes in locally advanced pancreatic cancer, we can expect 33 months after neoadjuvant therapy, and then after resection, 33 months from resection. Of course, it's not only about surgery. I now only talked about surgery, but it's about interdisciplinary care, and therefore this is also only something for centers. And with this, I would like to thank you for your attention.